Hello and welcome to our first lecture in our diagnostic imaging section titled State of Imaging in Physical Therapist Practice. I'm Dr. Brian Young and I'll be guiding you through this session today. Here's a list of topics we'll be covering. We'll have some definitions of radiology, a little bit of history lesson. We'll go through some thought distortions about imaging and its use in medicine and physical therapist practice, and these are things that we all face. We'll go through some current evidence that supports PTs and the ability to refer and recommend patients for imaging, and we'll cover some practice opportunities and expectations, and we'll cover most of those last ones in our next two short lectures. Radiology is often used interchangeably with the terms diagnostic imaging. You may have noticed in a hospital or a medical center that it could be listed as a radiology clinic or diagnostic imaging. This means the same thing. Overall, what it means is it's the branch of medicine which uses the radiant energy and radioactive substances, which include X-rays, to help with prevention, diagnosis, and treatment of disease. Prevention perhaps could be screening, such as tuberculosis. Diagnosis could be someone with a ACL tear or a fracture. And then treatment of disease may be someone who receives nuclear medicine for treatment of a tumor. You may see different names for different modalities of imaging. And the first one could be radiographs, and these are often called plain films, X-rays, conventional or standard radiographs. They all mean the same thing, and they're the picture here at the bottom right, which is your hands that we would typically think of as X-rays. Other modalities that could be used are CT or computed tomography, which is really a series of X-rays, scintigraphy or bone scans, magnetic resonance imaging or MRI, and also musculoskeletal ultrasound. We'll be exploring each of these within this course and also a few other applications such as to the neurologic system and also the cardiopulmonary system. Most of us are familiar with musculoskeletal imaging. We may not have recognized that as we just go to get imaging of bones or joints, but this is really musculoskeletal imaging, and it can also be called MSK or orthopedic radiology, and this covers most of the musculoskeletal system. These are often done with conventional radiographs as the first tool to be used in this, and that's where most diagnostics begin, is through the use of radiographs to get a basic appreciation of bony anatomy. It's usually time and cost effective and overall has low risk. There are a few imaging types that will have much higher radiation exposure, but with a careful assessment and ordering of imaging, we can keep that minimal for the majority of our patients. Other areas of interest to the PT besides musculoskeletal in the use of imaging. The first one could be neuroimaging. If you're working in a rehab center with individuals who have sustained a stroke or a head injury, neuroimaging such as the brain and spinal cord, or functional MRIs to assess blood flow in the brain in response to stimuli, can be very helpful in understanding their lesions, their impairments, and working to identify ways that you may be able to help and assist them. Additionally, cardiopulmonary, cardiovascular imaging can be helpful for heart, lungs, as well as someone who might have a peripheral condition such as DVTs that we know can progress to pulmonary emboli, or someone may be at risk of atherosclerosis. There may be findings that are important to you in your area of specialty within physical therapy. And there's many more that we could list here, and I'm sure many others that are going to be further expanded upon as research continues in the use of imaging within medicine, and specifically for us, rehabilitative medicine. Let's have a short history lesson about the beginnings of radiology. Where did this start? Well over 100 years ago, in 1895, Roentgen discovered X-rays, and in 1898, Marie Curie discovered radioactive elements. So it all started pretty quickly there at the toward the turn of that century, and many uses of these were explored, certainly in medicine, but also with forensics and police work, archaeology, marketing, carnivals. Let's go see this new contraption that can show pictures inside your body, and even superheroes. As listed in our textbook, were given X-ray vision. Military began using this shortly after these were discovered. World War I occurred. And so in military use during the war with injuries, tuberculosis was very big at this time, and eventually branched off into nuclear medicine if we think about the events in the 1940s and the study of nuclear medicine and fission and fusion. Radiation safety, however, did not begin until the late 1940s, or really much attention to that because of the after effects of the whole dropping of the bombs in Nagasaki and Hiroshima. And shortly thereafter, much more work was done to help protect workers and patients in radiation safety. And other advances continued. Sonar technology was brought into becoming a precursor to diagnostic ultrasound. In the 1970s, CTs were developed, and in 1980s, we had MRI being developed. Overall, these have really been a physician tool that they can use these and tell us what we need to have, and they're the controllers of this information, but yet that's changing, and that's a good thing. And it's not to minimize the role of the physicians, but it's to show that others have a unique need for this same information and may apply it differently, all for the care of this same patient. We do know that imaging can provide an objective look. We can't see through skin without imaging, and so we make judgment and use tests and measures, but imaging can provide a bit more objectivity, but yet it's still not perfect, and we'll give some examples of that here shortly. Specifically for physical therapists, use with imaging really began about 50 to 60 years ago in the Vietnam era, around 1970-ish, when military PTs were beginning to get imaging privileges due to a shortage of orthopedic surgeons. A lot of direct access work came as well there, although the military was not the first with direct access. There's been expansions in the U.S. Some health systems in California, in Georgetown, that have built in imaging components. Many state practice acts are beginning to allow imaging referral by physical therapists to help expedite care. Some states clearly allow that, some states don't. Some states are silent and they don't have a position in their practice acts yet. So make sure that you research the state that you want to practice in, and I'll tell you that Texas specifically states we can't because in the Radiological Technician Practice Act, they can only receive imaging orders from providers, and physical therapists are not listed within the Texas definition of medical providers. So you can't just look at the PT Practice Act. We have to look across other practice acts as well to understand this. But APTA's House of Delegates in 2016 did issue a resolution for us to look at getting practice authority across states and legislative efforts, and hence we do more teaching of this year by year within programs to help prepare physical therapists to order, but also to understand the integration and application of imaging to current practice. It just shows the current states at the end of 2023 that allow imaging specifically or through being silent in their Practice Act. And it's a small percentage, but it's growing. There were about 2 to 3 that were added the last couple of years. And so it's slowly morphing and getting more use out there and acceptance. Now, not every state allows the same type of clinical privileges. Some may allow x-rays only. Some may allow x-rays and MRI. Others may allow whatever it is that you use or want to refer for, including bone scans, CT, etc. So it varies, and not every state is the same. There's not a common Practice Act. Maybe someday we'll get there. Ultrasound, diagnostic ultrasound, can be a little different in states, and many physical therapists are becoming credentialed in rehabilitative ultrasound medicine and diagnostic ultrasound. And we can talk about that more in a few weeks when we cover our ultrasound session specifically. But suffice to say that there's more that we can do in the realm of ultrasound, which is really up and coming and not used as much in the US as it is in Europe and Australia for diagnosis, and it actually is a much safer and real-time modality that can be very effective. And so keep your eyes out for opportunities on the use of ultrasound imaging from both a diagnostic and a rehabilitative perspective. There's some great things that are coming out with it. If your state doesn't allow you to refer for someone directly for imaging, why would we want to have this course? And my thought to that, or my response is, every area of PT practice will utilize imaging results. Integrate the results into the patient examination as well as the response to treatment. Identify when further workup is warranted, which may include advanced imaging, and refer a patient back to a physician and specialist. This ability to directly refer to imaging for either initial or follow-up imaging is contingent upon other skills that we have, such as range of motion, muscle testing, neurologic examination, assessment of someone's progression or regression or response to treatment. Are they getting better, worse, or staying the same? And really, these should merely be the act of knowing when the PT should be the one to write the referral, for imaging appropriately, write the referral, and timely communicate the results to the patient and other medical personnel when advanced care is indicated. I'll also add that, okay, well, what if I can't refer? I can still take everything I'm going to learn about imaging along with my practice, and I can certainly pick up a phone or write a note and recommend imaging to another provider, and that if for them to consider for this patient to order. And I can come in with the best objective data and response to care that I can get through my clinical work with this individual and recommend other activities, imaging, workup, etc. that would be required because they may not fall into my scope of practice, or the hypothesis something that may need care beyond what we can provide as physical therapists. So let's switch gears just a little bit and talk about this notion that x-rays provide objective data, but they're not perfect. They're not foolproof. And if we just take a look at this study here from Register and colleagues on the prevalence of abnormal hip findings in asymptomatic participants, they had 3 different radiologists review the slides or the imaging sets, which were MRIs, and they calculated the consensus, or how much did the 3 radiologists agree on findings. And again, these are individuals that are asymptomatic. For labral tears, there was a 69% consensus. For chondral defects, 24% consensus. Look down here for subchondral cysts, 16%. Fibrocystic changes of the femoral head and neck, 22%. So we have to be very careful with imaging, x-rays, MRIs, CT, and we can't just look at the pictures as what this is getting at to come up with a diagnosis. There are certain things that we would look at clinically to help with labral tear. Faber test, clicking, popping, sounds, maybe a sense of instability in that, perhaps. So we have to tie clinics to the clinical findings to a reason for getting an imaging order or getting an imaging exam. And sometimes these go different. And we have to be able to either recommend the imaging or take what imaging is given from that individual as they come to us and apply our exam. And do these correlate? Do these work together? Because we know that patients without symptoms will have pathology. Perhaps you saw these in some of your cadavers. Obviously, we don't know the medical history, but we have findings in there. And were these enough to cause problems from an impairment or movement system approach, or are they just findings that aren't of any consequence to the individual? So think about this as we learn to apply imaging and how imaging is used as a component of a physical examination. It's just another tool within your toolbox. So then the question becomes, well, how accurate are we in assessing someone by their physical exam and their diagnostic accuracy of what they need? And this interesting study here by Dr. Joseph Moore, a physical therapist, retrospectively looked at 560 cases of patients with MRIs and how they were assessed by physical therapists, orthopedic providers, and non-orthopedic providers, and the accuracy from their physical exam to their findings on imaging. And what we see here in the percent agreement is certainly orthopedic surgeons had the highest agreement here, but physical therapists were just right behind with our ability to use the same kind of physical examination skill set as orthopedic surgeons. As we see these non-orthopedic providers, so family medicine, physician assistants, nurse practitioners, much lower perspective of agreement in trying to get the diagnosis they think is going on with imaging and having those confirmed and being accurate. So again, if we can tie these together with a physical exam, we can see an elevation of accuracy so we can get the most appropriate care delivered for our patients and clients. So from this Moore study, better diagnostic accuracy. We're equivalent to orthopedic surgeons, but that's not just because we have the label of PT. It's because we learn and apply and grow in our skills. PTs trained in ordering imaging and who can correlate their findings really can do this safely and accurately. And if we can do this well, we're now minimizing risk to patients. And what risk might those be? Well, radiation exposure. Delayed time to diagnosis from when they present to the medical system, and we can get more accurate and appropriate treatment for these individuals. So lots of benefits about using imaging appropriately. Well, the first study from Moore was in a military system. The second one is also in a military system. And we know in the military, PTs in the military have had a higher level of practice or expectation of practice and have had these skills for 50-some years. I myself spent 21 years in the military and have about 21 years of direct imaging experience. And so we're going to look at one other study in the military, and then we're going to switch over to how civilians or non-military PTs who have had training work with this. But this study by Michael Crowell looked at the diagnostic imaging utilization in a direct access military sports clinic. And they had 3 board certified PTs and 1 non-board certified PTs, with most of their patients being direct access. And they used a really compliance with what's called the ACR, or the American College of Radiography, and they have appropriateness criteria. If a patient meets certain criteria, there's a certain type of imaging that's most recommended. And we'll cover ACRs here in one of our upcoming sessions in this module. But suffice it to say that we want to look at and assess from external reviews how accurate are we documenting our exam findings to be able to order imaging for patients. And what we're finding here in PTs is they were 83% compliant in ordering imaging appropriately. Doing a physician comparison, general physicians, about 50 to 74% compliant. So again, tying clinical exam with needs of imaging, PTs can do this pretty well. Overall, only 8% of patients receive MRI and MRA out of all of these because of an appropriate, mindful approach to imaging in the clinical examination. Very low utilization of MRIs and MRAs. So another benefit, cost savings and not needing to do unnecessary procedures. So again, great. Those are military PTs, but man, I want to work here in this civilian sports clinic in my community, take care of my friends, my neighbors, my community members, and really be here. How does this evidence support what I want to do in my practice? Well, let's take a look at this. Similar to the Crowell article, Aaron Kyle, who is a physical therapist up in the Chicago area, looked at civilian PTs in a civilian medical center for their diagnostic accuracy in ACR guideline choice based upon clinical examination. And when they looked at these, and there were radiologists in both of these studies that reviewed the ACR guidelines and determined the appropriateness, right? They're the experts, quote unquote, if you will. 91% of these were considered appropriate by the radiologist. That's a great order if we look at how the Crowell study showed that about 50 to 74% of physicians were accurate, but we're again showing 91% of PTs were very accurate within their recommendations for imaging. There were inappropriate ones were all MRI, and we'll see that MRIs are common, but yet we often jump to MRIs for reasons, and sometimes this is because plain films were not ordered first. And imaging has to start with plain films in almost every case. There are a few exceptions, but the basic rule is we start with plain films. So what's interesting about this study by Kyle is that once the PT orders imaging, we know there's different things that we can get. You know, any exam that the PT does, we can consult with somebody to help manage. Or send them off to another provider because they may not belong in our clinic. We can treat them, or we can treat and refer them as well. And what we saw that over 70% of the individuals, despite the imaging need, were still being managed by the PT. So just because we send them for imaging doesn't mean we're done with them. They may come back with no findings, or something that's there but yet not so impacting that we have to go somewhere else. We can still take care of these patients. So keep that in mind. It's just another tool in our toolbox in helping to manage for those who are appropriate to our care. Again, these last two studies were direct access. I won't be doing this as a student or clinician. Do I need to know this? Well, every area of practice will have this question, and does this patient belong in my clinic? And there's many ways that we can answer this, but it all boils down to our exam, our clinical practice, our scope of practice, and it doesn't matter if they're direct access, if they're referred, or if they are the 4th or 10th visit coming in. We're always looking and answering this question and mulling it over. as we assess patients and their response to care. And so determining need for further workup, including imaging, is the responsibility of every physical therapist. So these are a few of the topics that we covered in this section. And at this point, what I'd like you to do is take a stretch break, and then when you're ready, jump into our next lecture of our 3 lectures in this series, and then we'll look forward to seeing you in class. Thanks so much.